Should we make a start? I can see that we've got Carsten and Andrew with us now. So we've got a lot to get through this afternoon. So I will hand straight over to Carsten and Andrew to introduce this session. Carsten, Andrew.
Carsten, go ahead. My name is Andrew Spiegel. I am the board chair of the World Patients Alliance, and it's really our pleasure to welcome everybody today from our perspective. And I want to start out by, of course, thanking our partner in this, ISQua. Carsten will tell you all about the organization, but I'll just spend a moment saying thank you from the perspective of the World Patients Alliance. We are a relatively newly formed organization. We're only a few years old, but we have already grown to be the largest patient organization working across all diseases. We are knocking on the door of 400 patient organizations from more than 113 countries. So we're really proud of how far we've come, and that the fact that we are representing all disease areas in all countries. So I want to thank everybody for attending, and thank, of course, the WPA staff for helping put this together. And with that, I'll turn it over to Carsten.
Thank you. My name is Carsten Engel, and I'm the CEO of ISQua. It's also my true pleasure to welcome you all to today's workshop. It is a result of the relationship and cooperation agreement that has been established between ISQua and the World Patient Alliance, and I look very much forward to this day. We are an organization whose members traditionally have been from the provider side, quality experts, patients working in healthcare, but also a lot of researchers, and we think it's a very good synergy in joining up with the World Patients Alliance to promote the issue of person-centered care in common. We are reaching out directly to patients as well, and we have established a patient and family-centered advisory council, of which Anna Edwards is a proud member. And that's because person-centered care is an issue that's close to our heart. As our name says, our mission is to promote quality of healthcare, and there can be no true quality without person-centeredness. It's not an add-on that's nice to have, but a core condition. And our mission is to spread knowledge that can help achieve it, and that's why we partner to prepare this workshop. And I want to thank the organizers and contributors for the effort, and I hope that you all will enjoy spending an hour and some minutes with us. Thank you.
Thank you, Carsten. And thank you, Andrew. So, yes, welcome to this workshop on person-centered care run by the World Patients Alliance and the International Society for Quality in Healthcare. As Carsten said, this is our first corporate collaboration, and hopefully will be the start of a very special relationship in which we can run more of these sessions. Today, I'm really excited to let you know that we have an expert panel of patients and clinicians who are going to talk us through their differing perspectives on patient-centered care, taking into account various different health systems across the globe. My name is Anna Edwards, and I'm going to chair the session today. I am, as Carsten said, one of the honorary advisors to the ISQua board, focusing on person-centered care. I'm a barrister by background, but I've worked in health and care for many years now, initially for the regulator in England, and I'm currently working for the NHS, heading up the National Staff Retention Programme. However, for the purposes of this workshop today, I am first and foremost a patient. I've had Crohn's disease for over 20 years. I've had multiple major surgeries and accessed all parts of the English health system. I've seen the best and worst of patient-centered care, so I'm really, really happy to chair today's event for you and see how much we can learn together on this important topic. We are going to start with a lecture on person-centered care, and then we will hear two patient carer perspectives, and finally we'll hear two clinical perspectives. Please do post any questions or comments in the chat. And we're going to try and get to as many of them as possible at the end. So that's enough from me, because there's a lot to get through this afternoon or this morning, depending on where you are. So we're going to start today with a lecture from Dr. Paul Bertalden. Dr. Padalden lectures at both the Dartmouth Institute in the US and John Coping University in Sweden. For about 5 decades, Dr. Padalden has practiced and taught about the leadership of improvement of healthcare quality, safety and value. And he is a world leader on research into person-centered care. So we're incredibly fortunate to have him with us today. Welcome and thank you for being here, Dr. Padalden. I will hand over to you.
Thank you very much. I'm privileged to be with you all and appreciate the opportunity to have my remarks in my first language, even though I recognize that that may not be the case for everyone on this session. Let me begin by trying to share why I prepared these words. Some perceive that the term person-centered care and the term co-production of healthcare service are simply names of current but always changing change ideas. I wanted to suggest a deeper connection between the two and to illustrate how they invite a helpful reconsideration of some of our basic thinking habits as together we try to make better value healthcare service for the future. From the excellent monograph that Gro Berntsen of Norway led, we read that the person is an individual with an identity, a history, a cultural and personal background. The patient is a secondary role the person takes on each time they interact with healthcare service. Likewise, professionals are persons first and take on the role of their profession second. Person-centered care builds on the recognition of both patients and professionals as humans first. And further, every person is born with a body and health that they own and for which they are responsible. Professionals and the system and payers must by design support and involve the patient in a co-creation of every decision on both goals and processes for care at all levels of care. Person-centered care embraces the patient as an equal partner in the design and co-production of the patient journey towards meaningful goals for the patient, together with the professionals and the system and payer. A successful patient journey supports what matters to the patient within professional, legal, ethical, and economic constraints. Person-centered care is a sharing of power to ensure that the answer to what matters to you drives care decisions. Patients and professionals work together within the constraints set by the care system in a care process to achieve goals that are meaningful to the patient. Against that backdrop, how might we think about the co-production of healthcare service? Well, with the fewest words, you might use the definition, the interactive work and contributions of the two parties necessary to make a service. Each word matters. For example, two parties might refer to because what is real or key in the service making are the people who are involved. They may be known by the name of the role they're playing in the development of the service, but each party may in fact be also more than one person. Well, each word matters, and I think that that's a helpful starting place. A more complete definition might read something like this: the interactive work of users and professionals in the initiation, design, creation, development, delivery, assessment, and improvement of the relationships and actions that contribute to the health of individuals and populations through mutual respect and partnership that notices and invites each participant's unique strengths and expertise. Let's try to discover a little more. And I begin with the observation by the writer Marcel Proust, who said that the real voyage of discovery consists not in seeking new lands, but in seeing with new eyes. First, what are good health-related services? Well, they're usually made by two parties. One, whose health it is, who brings knowledge of the lived reality of the particular condition and this person's access to helpful resources. And the other, who brings additional generalizable and useful knowledge about the condition, the skill, experience, habit, and disposition acquired from similar situations to the shared work. We recognize that health, like learning, is hard to outsource, even to a well-meaning professional. But what informs the co-producing of healthcare service? Well, I think there are at least four streams of knowledge, skill, and habit. The patient person and the professional person, the blue and the yellow, bring understanding of aim and their lived reality, the social supports and resources that they have access to. The green is knowledge of the as-is system and the navigation of the journey through that system of which both are a part. And in that knowledge, we understand what's working and what's not working. And the red stream has to do with science-informed practices. Sometimes we refer to evidence-based medicine, but Trish Greenhalgh has helped us understand that actually science-informed practice might be a better way to do it, because not everything we do has evidence in exactly the same way. But it's not just a name, it's a system of knowledge or a group of epistemologies that give us insight into the disease or the condition. It's a group of epistemologies and knowledge systems that help us understand the illness experience. And it's understanding of what goes into the design and execution of a service. And it's really the integration of those three big categories of knowledge that we in fact bring together as we try to inform our work by science. And as we do, we're cognizant of the limitation that circumstances play, as Ortega y Gasset said, that I am me and my circumstance. And so the circumstances under which these all come together influence the expression of our ways of knowing. And as these multiple streams of knowledge are woven together, we can explore the service-making logic that's at work. I like the contribution that John Ballot and his colleagues in the UK bring when they suggest that we can put on a pair of glasses. One lens focuses on kin and the other lens focuses on task. And when we look through those glasses, we can begin to discover what that service-making logic involves. So what is a healthcare service? Well, I think it's a relationship and an action, each of which has many different attributes. And those two are held together by knowledge, skill, habit, shared power, trust, and a willingness to be vulnerable. And it's the two parties that are involved in making all of this happen. Co-producing a service actually involves many different activities and roles, commonly including, as Elke Loeffler and her colleagues have suggested, co-commissioning, co-designing, co-delivering, and co-assessing. But as we begin to explore the logic of making a service, we can see that persons bring their personhood or identity and their ability to play a variety of roles in the co-creation of a healthcare service. And as I have had the privilege of observing people involved in this work, I've seen some of their struggles, role and identity, as they name each other and the contributions each brings to the work is sometimes a challenge. They confuse identity of person with the role of patient and simply refer to the individual as patient, not as person, sometimes known as patient. There's a deep commitment to a previously learned product dominant logic. And I believe that that logic is a limiting factor in our ability to understand the nature, the interactive nature of making a service. We have legacies that have frequently diminished rather than acknowledged and celebrated the underlying kinship that enables interdependent and human work. And we have experienced the effects of role-related burnout, runaway cost, and real risks that are often experienced as limited attention to safety. As a start, to improve, we must begin by carefully listening, thoughtfully reflecting on our own habits and dispositions, our attention to the words we use, and our ways of attracting each other as kin to this amazing work of change. But we live in a complex world, and as 21st century citizens, we need news and information that offer hope, which includes clarity regarding health ownership and new ideas and resources and measurement that is useful, new partnership energies and shared aim. But it's not just hope. A second attribute or cluster of attributes has to do with agency that comes from role clarity and task and kin views of service dominant logic for health, which recognizes shared work and access to resources. W. Edwards Deming once wrote to me and he said, "Paul, you should focus on the zeroth order." Now, he was a statistician, and x to the 0 power is always 1. So he was simply, that was his way of saying, start at the beginning. Don't start down the road. Start at point number 1. And the third cluster of attributes of useful news and information for 21st century people is dignity, the kinds of concerns about what matters to you, the clarity about whose health it is, new insights into resources and access to them, and more design and redesign space. I've been informed by the work of the journalist Amanda Ripley and the Christian Science Monitor, who have adopted those 3 different clusters of attributes for news and information for the 21st century person. My sense is that there's many more words that could be said, and I simply wanted to take my allotted time and stay within that. And my closing reflection is that every system seems perfectly designed to get the results it gets. And so with that recognition, we have an invitation to redesign what is done if we seek different results. There's many more things that could be said and places to read about all of this. A couple of them are listed on this slide, which are in your packet, and you can see that. The podcast series that we recently put together is another way to access all that. But I wanted to close simply by saying thank you for this opportunity.
Thank you, Dr. Patalden, for those insights. I particularly liked the bit about that partnership between provider and patient, and the knowledge and skill existing between the two. And I have to say, it always seems to be that the knowledge and skill sits with the clinician and not the patient, which of course is quite wrong. But it's interesting, because if you have the ability to build a relationship with the clinician over time, that changes. So it very often is different at the outset of a relationship, and I suppose that's where you start to bring in those concepts of trust, and which are
That's
alive
right.
and well in any relationship. Yeah. Thank you so much. That's really interesting. As I said at the beginning, I'll leave questions to the end so that we've got time to get through all of our speakers, but do start thinking about them now and post them in the chat, and we will try and get to them later. We're now going to move on to our next speaker, who is Lisa Maurice. She is going to share a really moving story with us from a patient carer perspective. She lives in the US and has many years' experience of navigating the health system there, and now uses those experiences to drive improvement across the globe. Lisa, we are so delighted you're here today. I'm going to pass straight over to you. Thank you very much.
Thank you, Anna, and thank you, and thanks to Hussein Jaffrey for your support in helping me put this together. I'm really honored to participate with this international body of thought leaders who can change healthcare today. And I'm particularly honored to follow Paul Batalden, and really thank you for your considered remarks, Paul. And I want to build on what you said. The principles of patient and family-centered care that were developed by the Institute for Patient and Family-Centered Care, though based in the United States, an international organization led by a nurse whose name is Bev Johnson, the core concepts are respect and dignity, for starters. Something that you mentioned, Paul, persons bring personhood, you said, or a role and identity. It's really talking about the value of a person and treating each person with respect and honor. Then the next principle is information sharing, which is really sharing of information to the extent the patient would like. I am an information person, I'm a media person, and I want to know everything I possibly can about a healthcare situation. I know others who just aren't interested in the ins and outs of anatomy and physiology and microbiology and all of those very important things, and really rely on you, the provider, to have that information base and knowledge. Where they have information, though, that you probably want to share is information about themselves and who they are. And so in that sense, you can share information, even if you're not sharing what we may call a more academic sense of information. The third principle is participation. And that includes both at the clinical level, where we talk about issues like shared decision-making, where with a thoughtful approach, the patient is brought into making decisions about their own healthcare process and what that is going to look like for them. Again, getting to what Paul said, what matters to me, and the context of treatment and care delivery with what matters to that person. And also participation in process and decision-making at the system level. And this gets to the idea of inviting patients to participate in advisory councils and other research that one does with patients to determine what they want, not on the individual basis, but as a group and at the system level. Every business that is successful talks to their customer base, every single one. But healthcare has not viewed patients as a customer base. And it's very important to change that mindset and bring patients in as part of co-production and collaboration. And that's the last point here, is collaboration, which is really co-production at both the clinical and at the system level. Next slide, please. So I want to tell you about my little kiddo who has endured to date 46 surgeries and has had 3 jaw advancement surgeries to bring the jaw forward about that far, which is probably about as far as that can go in order to have an open or patent airway. We want to talk about, in the clinical setting, what that has meant. Now, these particular pictures are from the first jaw advancement surgery that my kiddo had. And the devices that you see attached to the jaw are distractors that are put in, and then a screw is turned and those distractors move and move the bone with it. It's extremely painful. It's a hard process. My kiddo has a severely compromised airway, and you cannot, for example, if you're intubating, visualize the airway at all because of the acute angle that the airway has. So when my kiddo had this particular surgery, the doctor wanted her to be able to eat in 4 days. 4 days after surgery, taking food by mouth sufficient to support herself. Didn't happen. In fact, I said, I think we need a feeding tube. And the doctor said, but this other kid who's only 7 and my kid was 12, this other kid that I did this procedure on the same day is already eating waffles, which is like pancakes, a breakfast food. And he said, so your kid should be able to do that too. But the other child had the jaw advancement surgery not to obtain an airway or improve an airway, but for largely dental and cosmetic reasons. We had it because we didn't have an airway, and that drive to protect the airway and the difficulty my kid had swallowing all played in to eventually my kid had to go home with a feeding tube. So all patients are not the same. They need to be looked at individually, and that is part of person-centered care. Who is this person? What is their situation? Not all patients get the same Band-Aid, the same treatment. Patients are individuals. Next slide, please. On the system level, we talk about collaboration with patients and families. We had a patient and family advisory board at the Children's Hospital my daughter was treated at. And at one point, the leaders of that came to the moms and said that they were so excited because all of the patients who had to get blood draws from the outpatient phlebotomy practice laboratory, they only took 2 times to get the blood out. This was presented as such a great thing to the moms of the advisory council, who all said, no, wait. So you have about 8 moms standing around saying, that's not our experience. In fact, the day before that, we had had 7 tries and had to actually be sent home to try again another day because you just couldn't get the blood out of my kid. So that led the leaders at the hospital to say, but they said in the lab, they were only taking 2 tries. The parents are saying that's not true. They would never have known if they didn't ask the families that the people in the lab were not giving an accurate depiction of what was going on. The hospital ended up totally overhauling the outpatient lab, which did mean some personnel changes to get some people who would accurately report what had happened. Next slide, please. The kinds of things they introduced included ultrasonography and other techniques to find good veins for blood draws. They hadn't done that before because they didn't need to, because they always got it in 2 sticks, didn't they? No, they didn't. And so that improved their accuracy in having fewer pokes for the children. They added child life to the clinic so they could work with patients receiving blood draws, and used things like distraction and other techniques to help the child be more calm during the process. And they improved the training of the phlebotomists. They used better use of numbing and those distraction techniques. That is just one example of how collaboration with patients and families can improve practice and lead to better outcomes. So you have person and family-centered care at both the clinical level and the system level working together so that you have better outcomes in the long run. I want to thank everybody again for the opportunity to share just a little bit of our story, and really appreciate the great work that's being done by ISQua and the WPA. Back to you, Anna.
Thank you, Lisa, for sharing your story. Yeah, it makes for really interesting and, to be honest, sometimes quite difficult listening, and much of it resonates with me on quite a personal level. I guess the thing is, you know, it's such a great example of quality improvement when co-production is done well, that it makes me wonder what the possibilities are if we were to take this approach more frequently. But yes, thank you so much. Again, please post your questions or comments for Lisa in the chat. Next, we're going to move on to a different perspective again. We're delighted that Rebecca Chirenga has recorded a piece for us. She's going to share her experiences from her work with Women in Communities Zimbabwe, where she is an executive director. And then she'll be joining us towards the end of the call live. So Rihan, please can we play Rebecca's recording?
Good day. My name is Rebecca Chirenga. I'm the Executive Director for Women in Communities Zimbabwe, presenting on patient-centered care, representing the developing countries. Patient-centered care is about treating a person receiving health care with dignity and respect, and involving them in all decisions about their health. Patient-centered healthcare means that the patient, families, carers, and patient advocates are able to participate in trusted healthcare systems, not only to serve them well, but also to respond to their needs in a compassionate and comprehensive manner. Maternal mortality, the death of a woman from direct or indirect obstetric causes, more than 42 days, but less than a year after termination of pregnancy. Complications of pregnancy or childbirth can lead to death beyond the 6-week postpartum period. The background to this report is that maternal mortality in Zimbabwe currently stands at 614 deaths per 100,000 live births, which is one of the world's highest. According to latest statistics from Ministry of Health, 12 women die due to pregnancy-related illnesses every day in Zimbabwe. This was in 2016. One district clinic in Shurugwi caters for about at least 2,000 people in its surrounding area. Rural women are at a significant higher risk of dying from pregnancy when compared to women living in urban settings. Reducing maternal mortality is priority of Sustainable Development Goal 3, and the target is to reduce the global maternal death per 100,000 live births by 2030. What challenges do expectant mothers face, or what did they face before our intervention? Although there are over 1,500 health facilities in the country, many of them are still hard to reach areas that are not yet serviced. Traveling long distances to the clinic is a difficult task, more so when for heavily pregnant women. There's also the challenge of delay in seeking health due to these distances, delay in receiving expeditious and effective care at the health facility, poor public transport services, clarity on application of user fees, lack of crucial health education and information. So in 2010, Women in Communities Zimbabwe took up this initiative. The community of Ward 10, which was the closest in proximity to the Central District Hospital, collaborated with Women in Communities to resolve the maternal health problems in their community. Community-based planning to engage in participatory and reflection approach helped to ensure inclusivity of the whole community. Transparency and open dialogue and consensus building on actions to be done and key roles identified. There was a great need to improve the current state of affairs to prevent further casualties. A community health team, which comprised community leaders, health officials, women of childbearing age, and the WICO team, was established to ensure the community is involved in the planning and implementation of the project. The existing state of affairs did not allow active participation of the patients to more accessible and effective healthcare services. It was the prerogative of the health ministry entirely. Next. The team was then tasked to map the way forward to improve the maternal health gap that the community was experiencing, and they discussed how best the community would resolve the issues. Community dialogue platforms helped to address the issues and lack of adequate maternity facilities in the community. They helped to develop community action plans based on local resources and capacities. The entire community was involved in the health, and the health officials began to appreciate the need to involve the patients in decision-making. Consultations continued even as the work progressed. Meetings were conducted, and community members in Ward 10 of Shurugwish, Zimbabwe, were seen here discussing maternal health issues. Next. The community mobilized themselves to make bricks and supply the other resources needed to construct the structure. They also identified builders among themselves to do the construction, which contributed immensely to the co-financing of the project. The hospital allowed the community to clear a site within its premises to enable the construction of the maternity dormitory, to take part in creating a social network between community and health professionals. the health committee arranged that the nearby villagers take turns to assist with any labor required and the builders themselves were part of the community. So women of childbearing age, the elderly, and the men participating in the problem solving, in the health problem solving. So women and men in Ward 10 actively and equally participated in solving the maternal health issues in their community. Next. So how did this come out? The outcome, the construction of the shelter helped to solve the problem of distance, which was a big challenge and contributing factor to maternal mortality increase in Chirugwi. ISQua and the community constructed a 30-bed dormitory or shelter near the health center. This reduced the possibility of unsafe deliveries at home. Its purpose was to accommodate mothers as they wait for delivery ahead of their time and allow for access to information and education material. To this day, mothers can stay in the shelter as long as they need to, without incurring any boarding costs and in close proximity to the health center for delivery. The mothers also got access to health information, and the PMTCT program was implemented more effectively as institutionalized delivery was made possible and increased by about 100%. The information material was designed to the audience and disseminated to them accordingly. The information was made simple and comprehensive and easier to understand, and mothers were provided with information about PMTCT, HIV, and other maternal-related conditions, prognosis, treatment, and how they could help healthcare providers or be engaged in their own care. SRHR programs were also conducted with the mothers during their stay. Postnatal care and baby care lessons were given during the mother's stay at the shelter. Next slide. In conclusion, ladies and gentlemen, effective participation of the patients in quality improvement and service development activities in health services was achieved through the adoption of a range of methods, community dialogue platforms, community health committees, social networks, and the community building committee. This initiative was replicated to another community and established in another district and continues to serve the villagers and prevent maternal and infant mortality. The community became active in ensuring that the service had been improved and improved MMR and IMR and institutional deliveries and quick referral as the pregnant women were closer to the health facility all the time. This, ladies and gentlemen, was our patient-centered care program in Zimbabwe. I'll leave this to open for questions and contributions to what I've just presented. Thank you very much.
Great. Thank you to Rebecca for that account. It's really powerful to hear and interesting also to hear the differences between that story and the one that Lisa gave previously. And so fantastic to see that quality improvement through co-production really making a difference. And not only that, but also seeing that scaling up as well, which is absolutely fantastic. What a wonderful account, and a real joy to hear. As I said at the beginning or earlier, Rebecca will be around later to answer any questions on her account. So next we're going to hear from Dr. John Brennan, who is a practicing general practitioner in Ireland. And for those who don't have the same health system, that focuses on primary care. Dr. Brennan is also a board member at ISQua, an expert in quality improvement and author of various articles. He is going to give our first clinical perspective today on person-centred care. It's a real honour to have you here, John. So handing over to you. Thank you.
Thank you, Anna. It's lovely to be here, and I am certainly truly humbled to be in such exceptional company today. The first challenge I suppose I have is the expert piece. I wouldn't necessarily regard myself as being an expert in anything really, but hopefully maybe I may come across as an advocate for an approach that I have experience of working in solving quite a difficult problem. Now, there is a warning on this presentation. We are going to be talking a little bit about sleep, which is always a dangerous thing, I think, to be talking about at this stage in a webinar. So from all of you out there, all the faces I can't see, I do need some input now in the chat box, please. I want you to rate your night's sleep last night from 0, I had no sleep at all, to 10, I had the best night's sleep of all time, so that we have a little bit of context for our discussion. Let's co-produce some statistics in that box just to get us all moving again and get our fingers and brains engaged. So the title for my presentation is What We Permit, We Promote. And the origins of this initiative actually come from me sitting in a quality improvement meeting in a large lecture hall in Amsterdam in 2018. And you'll see one of the world's great patient advocates in that picture in the bottom corner, Margaret Murphy. It was a talk on medication safety. And as one of the few Irish people in the audience, I was pretty embarrassed when this slide went up. To see that in Ireland, we prescribe, or certainly according to the OECD in 2017, prescribe more long-term benzodiazepine and related medications to older people than anywhere else in the developed world. And as a practicing general practitioner, where a lot of those prescriptions originate, I was pretty horrified and quite embarrassed to see that. Because as a GP, I know that for that age group, these medications can be incredibly harmful. They can create problems with balance and falls, problems with confusion and drowsiness, memory issues. But above all else, as a practitioner reflecting on that, I was particularly worried about, I suppose, the opportunity cost or the hidden harms of seeing such a high prescription rate for that medication. Because as a doctor trying to balance always person-centeredness with efficiency and all the people who need to be seen with all of their issues and worries and safety, I know that myself and a lot of my colleagues, the most efficient way to get through a busy day is through the prescription pad, to find a pill for every ill. And unfortunately, poor sleep more often is a symptom rather than a disease. And we can use the sticking plaster approach of prescribing a pill for that symptom without going into where are things going wrong with sleep? What's the problem? What is it telling us? Because often sleep is the first thing to go, for example, when someone is stressed or has a mental health difficulty. There can be endless physical problems that disrupt or upset a night's sleep too. And consequently, often the question really we should be going after is less about sleep and more about, well, what's the issue or the problem that's really sitting behind that, and how can we help? So needless to say, this is a problem nationally in Ireland for us, unfortunately, and one that's been building over a very, very long period of time. So coming back from Amsterdam and that conference, that quote was ringing in my ears. What's this problem like in our practice? Let's have a look. And as clinicians, let's look in the mirror and see, right, how big a problem is this for us, and what are we going to do about it? So I'll get you, Anna, to pass up the next slide there, whoever's moving the slides. Super. So as clinicians, the first thing we decided to do was look at our own data, and we found that we were in the bottom 50% of practices nationally when it came to prescribing these medications. Now, we do have an older patient cohort. I'm talking to you today from Ballyhale, a blustery Ballyhale in South County Kilkenny in Ireland. We do have an older patient cohort in this practice. This was quite a delicate conversation to have. I've only been working in the practice since 2017, but who was here for the 30 or 35 years before that were my mother and father. So I had to be very careful about how I broached this topic. But as a team, we looked at the statistics and we said, right, we're not doing as well here as we should be. And this is something we want to try and improve. Based on that, we started going into the realms of understanding why. Why might this be a problem for us? Why is our prescribing manifesting itself in this way? We spoke to other GPs and other practices about how they were addressing it. That was quite an illuminating experience as well, as other clinicians told us, well, what they did was they just brought the shutters down and they said, we're not prescribing any more of these medications. And I think that had the effect of fracturing a lot of relationships between people and their primary care providers. We spoke to one practitioner who spoke about fabricating a letter from a medical regulator that said his practice would be shut if he didn't stop prescribing these medications, and he would show this fabricated letter to patients to persuade them to come off these medicines. We decided, though, as primary care clinicians, that one of the biggest dangers in tackling this issue would be if our approach meant that people could no longer come and talk to us about the sensitive issues that they needed to speak to us about. In primary care in Ireland, there's no other way to do it but through relationships and continuity. That is the bedrock of providing good general practice care, and any solutions we wanted to take had to be built upon that. So we decided, listen, we didn't have all the expertise we needed to tackle this problem. So we started to reach out to patients of the practice, people who had experience of being on these medicines or caring for people on these medicines, and people who knew what it was like to try and come off them, and also knew how good it felt to be off them. And we recruited them to help us with our understanding. And over the course of just more than 18 months, as you can see, and into the beginning of the pandemic, when everyone's sleep got worse in Ireland, as the research would suggest, we managed to reduce our rates of prescribing in this area by over half. And we did not have one single patient complain or leave the practice as a result. I'll take the next slide then, please. So you might ask how we did it. Well, co-production was a core part of that. Our patient representatives, the people who offered to join us, were incredible assets to our team and provided the new eyes that Paul Batalden and Proust mentioned earlier, the perspectives that we needed to succeed here. They helped us from the outset hone our shared decision making. So while co-production was happening at the systems level in solving this problem across the wider practice, it was also happening in each individual consultation. We shared decisions with patients around medication safety. And in those decisions, with the information we provided, we said to the patients, well, what are the key things that you think we need to be mentioning about these medications? And all clinicians adopted what was designed as a triple message. The three big kind of reasons why someone might want to consider reducing. And they were falls and fracture, they were memory problems. And the third one was actually that when you've been on these medications for some time, they actually start to reduce your overall quality of sleep. They lock you in a lighter sleep. So even though you might start taking them to help you get to sleep and for a better night's sleep, over time, they will result in a worse night's sleep. So again, that the patients told us that was an important message to bring. And we shared decisions around reducing these medications. We designed different pieces of information to help people around decisions on these medicines. So good sleep hygiene information, safety notices about these medications and core messages, a sleep diary to help people track their sleep and different things that could affect it. That was all designed by the users, the patients of our practice in producing this change. The third thing that the patients brought was a strong social element. They took this outside of the four walls here and into the community. They spoke to their own pharmacists. They had conversations in the cafes and the post offices, on the street with their friends and family about what was happening here and about why this needed to change and how it could all be better. They also brought incredible energy to our team, new energy and new ideas and a wonderful accountability. As we looked around the room initially in person and then on Zoom as the pandemic took hold, we were seeing the buck stopping with us, and that helped to drive us forward. And this example, a quote from Alice, one of our patient representatives, was around the importance of words, as we're hearing throughout the discussion today, and that word stop. How that can be the wrong message to start with, how that can strike fear and terror and anger into someone's heart if they're worried that someone is going to take away a medication that they're dependent on or feel they're dependent on for a good night's sleep. Next slide then, please. And what I want to stop on kind of briefly then in working through that, and we're sort of skimming the surface today, are the very real challenges that we faced and that other teams face in trying to adopt this approach. We all feel it's the right thing, but practically speaking, it can be a big challenge to go from how things have previously been done to doing things this way. This list of challenges has been collated from both our own eyes as clinicians and our patients' eyes and our shared experience as a team in working together to tackle this. The first is around sharing power. And I think one of the core tenets of co-production is that power is shared, but can that ever be equal, or how close to equal can we get on that? Our patient representatives told us that they were always afraid that we were about to pull the rug out, that we would ultimately say, no, your involvement stops here and that's it. And the other question is, when you're starting with an issue or a problem, well, is the agenda ever really blank, or is it starting from the eyes of the clinician rather than from the eyes of the patient? And what does that do to frame the relationships and the actions that constitute co-production? The second piece then was around gratitude. How do we thank people? How do we reward people? Our patient representatives told us, don't even think about giving us money or any extra special treatment, because that'll make us less effective as patient advocates in this practice. And the third piece, the professional and patient relationship, we would have very close and long-lasting relationships with our patients. In the case of my parents, I said 35 to 40 years. And in that sense, as you get involved in these types of discussions, treading into these difficult areas, what does that do to the doctor and patient relationship? Does that add strain? Does it change the dynamic? Is that something that everyone wants or doesn't want? What's the cost there? The fourth one is around balancing perspectives, recruiting wide perspectives. I know certainly as clinicians sitting down initially in planning this work, we had difficulty deciding, well, right, who do we approach? How do we approach them? How do we make sure we get a broad range of perspectives? Are there going to be biases in how we select or how we pick people? Are we going to choose people that we think will agree with us? How's that going to affect this work? Very, very real challenges. And the last two then are two that unfortunately we are still grappling with and still struggling with. How the team evolves over time as people come and people go, how we sustain energy and renew this, how we continue to commit time and resources and energy and effort to this. And we're still solving those problems. I have to say, it's easier, we found certainly, when there's a big problem and an urgency to work on that together. The more subtle day-to-day things are a bigger challenge to grasp this properly and continue to find momentum and drive to work in this way to tackle. Last slide then, Anna, please. So to close then, and my contact details are there, and I'm happy for anyone on this call to contact me to talk about this further, because as I said, we only have a brief few moments to talk about it today. But for me, the key take-home points, number one, share. the new eyes, as Paul Batalden said earlier, share those new perspectives, and use that as a way of understanding problems to find the most effective and efficient ways to solve them together. Socialize this effort, this initiative, because this is about building relationships. And as we all know, relationships require time and common ground. They're built. The third is to strive. Strive to learn and to grow and to improve together. The fourth is try where you can to design for this to be sustainable around time, around energy, effort and involvement. And the last then is to succeed. And I would strongly suggest and urge you all to succeed by making sure that you do not let perfection stand in the way of good enough to get going, get moving, get learning, get growing, get co-producing. Thank you.
Thank you so much, John. That's a great, really wonderful case study and a good way of sort of pulling out where some of the real practical challenges exist in person-centered care. I suppose my reflection on your case study is also that we need to ensure that the care remains personalised for the individual, and so therefore not taking that drug perhaps and saying to somebody who does really need it, actually you can't have it because we've agreed that the rest of the population don't need it anymore, so neither do you. There will be cases where people do need it, and so it's taking an individual patients on their requirements. And certainly in my experience, I've had some not so satisfactory experiences from that perspective, with drugs that have been stopped or reduced in their prescription, usually opioids. But really, really interesting. Thank you. So we were due to have Dr. Kohli here next from India, but sadly he's been called away. So we're going to move on to our discussion section of the workshop now. I see that there's a bit of a discussion about communication in the chat already. And there's a question from Dr. Asif, which I'm going to open up to the panel and the speakers that are with us today, which is how can we ensure effective information sharing, overcoming communication barriers with patients to enable them to make significant contributions in decision making. I know, Lisa, you've already responded in the chat, but Dr. Batalden, Dr. Brennan, Rebecca, any thoughts? Dr. Batalden.
So I had the privilege to teach a group of junior doctors about how to do this. And I asked them to get a learning partner. And I gave them a worksheet that the two of them had to address. And this junior doctor had a retired engineer who was her partner. And first of all, the junior doctors resisted this idea because they, of course, knew everything that needed to be known about it. And I said, no, you have to get a learning partner. So, and it wasn't hard finding learning partners. People were quite eager to do this. At any rate, so the first one was this young woman doctor and retired engineer. And they had the questions to go through, and they went through the questions, and she came back from that experience and she said, it's unbelievable. This guy was trying to deal with congestive heart failure, and the doctors and the clinics were all focused on the measurements of his heart function. And what he really wanted to learn was how to cook, because his wife had died a couple of years before, and she had been the cook in the house. And so he was trying to eat safely and was trying to learn how to cook. And people weren't getting it. And so what this doctor learned was that she had to open the conversation differently. She had to open the conversations that she was having with patients, something like what matters to you or what's important to you. And that question, which she had been a little bit afraid of because it would lead to too much conversation in the clinic, but actually it helped her focus her conversation. So it's a matter of, to me, listening, and it's a matter of using good, helpful questions. And then I think those 3 tips about hope, agency, and dignity that should go into the construction of messages as we think about how do we move news for busy people facing complexity. That's what I think is ahead of us.
Thank you so much. And I would add to that actually authenticity, because what I wouldn't want is a checklist of questions that doctors go through, but it doesn't feel like they really mean them. So I think they've got to be authentically delivered as well. But yeah, really good points. Thank you.
She found it possible better actually to go visit the man's home.
Yeah.
And in the process, that's where they worked on the questions together.
Yeah, brilliant. But it's time, isn't it? Always time.
Well, she realized she couldn't do that every time with every patient. But what she could take away from that was the importance of her using different questions in the clinic office.
Yeah, yeah.
And I might add there as well. And I mean, I can start with the time piece, because I mean, certainly in our work, the number of patients that came off these medications completely, and you know, the volumes of milligrams that reduced have meant we are having far fewer conversations about problems related to these medications now. So there's a short-term cost to a long-term gain. And I think as well, you know, some of the work by Glyn Elwyn in this area around the structure of a shared decision is very useful, where that question, what matters to you, can come in, and how it can be used to hone that discussion as we work around choice talk, option talk, and decision talk, to frame good shared decisions. Because it is certainly my experience that where you spend a little bit longer to get to the real problem the first time around, everything becomes more efficient from there, as you work on the right problem, not necessarily the one that might be less well established.
Yeah, that makes complete sense, John. Thank you. I'm going to move on to another question, which Penny Cowan has put in the chat, which is, what is the goal of treatment for the patient and what are their expectations? And this seems to be, Lisa, a pretty good one for you to pick up, if I can pass to you.
Yeah, I think that is a really great question, and one that the professional in the relationship may assume is something like curing the disease or solving the airway problem in our case, for example. The patient may have a goal of treatment of being able to play football next week, or being able to see a grandchild be born. And those are not always concordant or similar goals. So that's why what matters to you may elicit a different response. We had an example at the Children's Hospital where a patient was admitted with really intractable migraine headaches. And the clinician goal was to get rid of the migraines. The patient goal was to be well enough to take college entrance tests. And getting the patient to the point where the pain level was enough that they could leave the hospital and take those college entrance tests was what was the most important thing. So that kind of assessment and communication is part of shared decision making. It's part of finding out what matters to me. And it's also part of achieving clinical goals and aligning clinical goals with patient goals.
Yeah, thank you. And Rebecca's put a response in the chat as well, that it's to get well, receive the treatment desired and go back home to your family. And for an expectant mother, the goal is going home with a live baby, which I think, you know, will be, absolutely right. And from my perspective, you know, I've got a permanent stoma, and when I was given that at 28, 29, I wasn't interested in whether it would save my life or treat my disease. I just cared that I looked disgusting. Who would ever marry me? Would I be able to have children? You know, I just didn't care about how it managed my disease. So yeah, I think those differences you draw out there, Lisa, are really important. I'm going to quickly move on to Jan, who's got his hand up before we finish. This will be the last question we've got. Jan, please come in.
Well, I'm very happy with the fact that we discuss now the importance of the answering of the question, what really matters to the patient. And I think it's so important that our care process starts together with the patient and looks, first of all, at the life goals of the person in front of us. What makes the life of this person worth to be lived? And if we can put that question central in our approach, you will see that we will do completely different things. And Lisa and John and Paul have already given excellent examples of that. So the question is no longer what's the matter with Mrs. Johnson, but what matters to Mrs. Johnson and what makes their life worth to be lived. If we would all have an app that we can fill in our life goals continuously, and they change over time as our life conditions change, and that is immediately taken up in our health record, and it is the first screen that pops up when the clinician opens our health record, our care processes would be completely different than they are nowadays, because we would focus and orientate our interventions towards our contribution to the achievement of the life goals together with the patient. And so I think this is a fundamental reflection. And in order to do so, I think we can learn a lot from the person-centeredness as it has been developed in other continents. I've had the privilege to work very often in Africa, and I have to say, and Rebecca will agree with that, person-centeredness, if you want to know what it means, go and sit with a provider, be it a nurse or a doctor, somewhere in Africa, and listen and look to what happens, because that's absolutely looking at the person, at the context, at the culture, at the history, at all the determinants that will influence their living conditions. And both looking at the individual and the community, I think, is a very important issue. And in the Western countries, we too much are only focusing on the individual. But as the Africans say, Ubuntu, I am because we are. We can only give meaning to our lives if we are part of a community that helps us to do so. And I think nowadays in the world where we are living in, this is extremely important. And our task, I think, as providers and certainly in primary care, is to contribute also to this kind of perspective, because we need it so much as a society. Thank you.
What wonderful remarks, and really reflective. Thank you very, very much for those, Jan. I had other questions. I didn't get to my own questions. I feel quite upset, but I'll pick those up with people individually because we've run out of time today. So listen, deepest thanks from me to all of our speakers, to those working at the World Patients Alliance and ISQua, who've helped us support and develop this workshop, and to all of you who dialed in and participated in the discussion. I think for me, you know, it's sessions like these that will really help us drive change in person-centered care, not only in our own countries, as Jan has just said, but across the world. There is much already happening, but I think there's still quite a long way to go, and the journey is so important, particularly if we can do it together. So thank you very much. I'm going to hand over for very brief closing remarks to Carsten Engel and Hussein Jaffrey.
Thank you, Anna. And thank you to all the presenters. It has been wonderful time spent with you. Paul frames the concept of person-centered care so well. And to keep it very simple, when I wonder what this is all about, I think of the question, what matters to you? And then I have much of the answer. Lisa, Rebecca, and John told us 3 different stories, but all of these stories shows us that this can be done and that it works. So the message to all healthcare providers that want to introduce this is that you should not be afraid of doing it. It may be, as John said, cost you some small costs in the short run, but I am very convinced that in the long term, and I don't think you have to wait very long for it, it will pay off, not just in terms of better quality, but also in terms of more joy in working and times and efforts that are now wasted saved. So go out and get on with it. Thank you.
Hi, I'm Hussein Jaffrey, and I'm the Executive Director of World Patients Alliance. And I'm very pleased, very, very pleased that, ISQua and WPA has been able to really bring together the healthcare providers and patients together to discuss an important issue. And I tell you, when we started discussing about this workshop, I think the first thing that came into our mind was, many of us have very different understanding of what person-centered healthcare is or what patient-centered healthcare is. So we thought that let's all get into the same understanding of what person-centered healthcare is. Let's bring the healthcare providers and patients together. And then, that might be the first step of, our organization working together. And then, bringing in more initiatives where patients and healthcare providers move along to other points, having the same similar sort of an understanding of issues and to beginning with the person-centered care. So I'm very happy, I'm very pleased that I think we started with this one. I'm extremely grateful to our speakers, to Paul, for introducing us to the issue of person-centered healthcare and co-production. I'm also very grateful to our, speakers, Lisa Morris, Rebecca Chingera, and John Brennan for bringing in their perspective of what patient-centered healthcare is, if they are a patient, from patient perspective as well as from healthcare perspective. So, I think we are over time already, but thank you very much to the participants as well. And I'm sure this is going to be in just the first event, and they're going to come many more of such events. So stay tuned. Thank you.
Thank you, everyone. Have a lovely afternoon or evening.